Thank you, Reinhard. It's a pleasure to be here, and it's always nice to be introduced by your trainee and fellow. All right, so I'll get started. I'm based at the University of Toronto. So I just want to give you a preamble before we start that almost everything you'll see today is because of working across disciplines. So I have an appointment in the Faculty of Medicine and in engineering, and almost all the work I do is because of working across disciplines within medicine and outside medicine. So I'll start off with what you see here, the sculpture by Albert Gheorghi. And my goal and the program's goal when we developed this a couple of years ago has been to find new treatments for treatment-resistant mental illness. At the end of the day, it doesn't matter. The nature of the intervention does not matter. It's about giving people hope, but also hope in a manner where there's evidence. So our emphasis is entirely on treatment-resistant conditions and trying to understand who improves and who does not improve, and trying to understand the underlying basis when people improve and people don't improve. This is my disclosure slide, which I have to do as part of my presentations. My research is funded through sources in Canada, predominantly, also in the US, and through industry funding. So I'll give you an overview today of the clinical aspects of interventional psychiatry, and then some research paradigms. It'll be a broad overview of the research we are doing. If I get into the specifics, each of them will become a talk by itself. But if there are specific questions, I'm happy to answer them. And I'll really focus on a few specific treatments. So I'll take roughly 15 minutes or so for each of these three components. Part of the reason for me to give an overview of the program we have developed is if other people are interested, and we have done this both in Canada and internationally, to develop similar programs, we are very happy to share our protocols. And, we really believe in open science, and we are happy to facilitate growth of the programs. It goes back to what I presented before. Treatment-resistant mental illness doesn't matter where, and if we can make a difference, we are happy to do that. So these are the components of the program which we have developed. So I'm based at two of the largest hospital systems in Toronto. And I'm going to be speaking today really about the programs we've developed at St. Michael's Hospital, which is one of the two hospital systems where this interventional psychiatry program is based. I'm also based at another hospital where I entirely focus on invasive brain stimulation. I will be talking about it today. So I'm the gatekeeper for the deep brain stimulation program, working with neurosurgery. I'm not going to be giving details about that, but if people are interested, I can go over that. So the interventional psychiatry program at St. Mike's, we don't do invasive brain stimulation. We don't put electrodes into the brain. It's non-invasive. So I'll only be speaking about non-invasive brain stimulation today. So we have three pillars: pharmacological intervention, brain stimulation, and a digital pillar. And within each of these, we have a clinical arm and a research arm. So we have a clinical ketamine program. We have a research program. I mentioned about working across disciplines. So this is work with anesthesia. So we are repurposing anesthetic agents as treatments for treatment-resistant mental illness. Ketamine, as you would know, has a lot of evidence. We are doing a number of trials with ketamine, and we are repurposing nitrous oxide, also called laughing gas, another anesthetic agent. We also work very closely with psychology for psychedelic trials, particularly psilocybin. So that's on the pharmacology side. On the brain stimulation side, we have a clinical TMS and ECT program. We also have an emphasis on take-home modalities of brain stimulation, and I'll go through that as I present. The last is a digital intervention pillar. We have an emphasis on measurement-based care, so we want to make decisions based upon as objective data as is possible collected during the interventions. So we do scales routinely right through the clinic, and we're trying to see how we can facilitate, deployment of the scales. And there's a whole digital therapeutics program. So I'll start off with the clinical first, and then more to the research component after. So this is the referral form. It's a busy slide, but the point I'm trying to make here is we have one referral for everything we do within the program. So all the clinical research, everything, there's one point of entry, and we have family physicians and psychiatrists across the province sending us referrals. So for context, I'm based in Toronto, which is the largest city in Ontario and in Canada. And we are an interventional program. By that, I mean, we don't take over the care of patients. We need family physicians and psychiatrists who will take the patients back after time-limited treatment. So if it's TMS, it is 4 to 6 weeks, or within research protocols, it is within the research protocol, and then they go back to the referring physician. It's the same as interventional cardiology or interventional neurology, where you are a tertiary quaternary site where you offer time-limited treatments, and then the patient goes back to the referring physician. That's how we keep up with large volumes, and that's how we're able to run our clinical trials. So we get referrals from across Ontario for the different things we do within our program. So this is the program flow. So we have people who have failed, who are treatment resistant, now also called difficult to treat conditions. And they come to us for TMS, IV ketamine, and then ECT. And we really have the flow where if people have not had an adequate dose duration trial with medications or psychotherapy, we don't accept them into the program. We do get a lot of referrals like that. We send them back to the family physician saying, go through the medications. If they don't respond, then send them back to us. That's the interventional model. So we get a lot of patients, at different stages. We have people who have failed ECT, for example, they've not responded to ECT and they want to come for IV ketamine. So that's the flow, and it's a digital clinic. I mentioned about measurement-based care. So we have an app, we have studies with wearables where we're actually collecting continuous data as people receive these interventions. People also have the option of participating in trials right through. So they could exit for experimental treatments, psychedelics, nitrous oxide, and in other things. And then there are patients who do not want ECT with some of the cognitive side effects, and then they go over to other experimental treatments. So this is another way of looking at the same. And I'm going to go through some of these, what you're seeing here, to give you an overview of on the clinical side and on the research side. I'll also focus more within the clinical realm on ketamine and TMS, as these are two of the emerging modalities with clinical evidence. So we really believe in multimodal treatments, and the goal is to combine things and not to have people receive one treatment only. So we try to do, to the extent possible, combined treatments, concurrent treatments, rather than sequential treatments. So, and a number of our trials, whether it's psilocybin and psychotherapy or ketamine and psychotherapy, is really to see if you can combine the two and show evidence for the two together. So, as I mentioned before, our focus is really on doing new clinical trials, often proof of concept, and many of the trials I'll show today are first in disorder trials, and some of them may fail. That's how clinical trials go, and the ones where we demonstrate feasibility and preliminary efficacy will then become larger, multi-site, more definitive trials. So we have an emphasis on working across disciplines, and if people are interested here or elsewhere to develop similar programs, you have to be able to work. You need to have people across disciplines coming together. The work within the brain stimulation program is very closely with engineering and neurology, neurosurgery, and within the digital pillar, it is really work with computer science and that department. So I've given you a brief overview of how our clinic is organized. Now I'm going to go through some newer treatments, particularly ketamine later, and then before I'll go through the brain stimulation, non-invasive brain stimulation modalities. So I want to give you the paradigm underlying interventional psychiatry and all new treatments within interventional psychiatry. So the conceptualization is that these are circuit-based disorders. Neurologists have always looked at their conditions in this manner. They want to know where is the lesion. They want to know the circuit underlying a specific symptom and where in that circuit there is a disorder which leads to the symptoms. Over the last 1 to 2 decades, the shift in psychiatry has been to focus on underlying circuits, the idea of circuitopathies. So you'll see that as I go through the new treatments under development, we are trying to precisely target specific nodes of these neural circuits. If you're doing deep brain stimulation, we're putting the electrodes deeper into the brain, but it is a node within that depression circuit we are trying to target. If you're doing TMS, we are targeting a superficial node, but it's still the same circuit which you're trying to target. Within interventional psychiatry, the best evidence for the circuit basis within the mental health conditions is for depression. So that's why you'll see that most or many of the emerging treatments are really for depression. And brain stimulation now is an accepted third modality as efficacious as pharmacotherapy and psychotherapy. It's the access issues which limit people having access to TMS, for example. But if you look at how effective TMS is, it is just as effective as pharmacotherapy is or psychotherapy is. So I mentioned about neural circuits underlying specific mental health conditions. What's also interesting is that you have shared circuits across conditions, and that's how patients present. They present with pain and depression. They present with Parkinson's and depression. And when you target the specific node for depression, often you also have other symptoms also improve. The pain symptoms can improve and the other symptoms can improve. And this is because not only do you have circuits underlying each conditions, but you also have shared elements of the circuits between conditions. And this is the comorbidity that we see clinically when we do research trials, initial trials. We try to exclude people to the maximum extent possible who have comorbidities, but in real life, people have a number of these comorbidities. And the reality is that you may see a lower effect for depression because of people having these comorbidities, but you're still targeting nodes which are of relevance to depression, but also to these other conditions. There's a lot of active work going on with, can we target 3 nodes at the same time? Can we target 2 nodes at the same time? I'm not going to be presenting on that, but I'll be speaking about work where, what has already been published on targeting specific nodes within the circuit. So this is ECT, this is interventional psychiatry treatments on one side and interventional cardiology on the other side. This is just to give you a feel for what the treatments are like, and you put them side by side. So with ECT, you're shocking the whole brain. It's like shocking the entire heart. It's like doing defibrillation. That's the ECT counterpart. With MR guided focused ultrasound, gamma knife, you're doing lesion surgery. With ketamine, psilocybin, MDMA, you're doing pharmacological cardioversion. It goes on like that. So basically, depression in some sense is, you can look at it as an arrhythmia of the brain, just as you have arrhythmias of the heart, and you're normalizing that with these interventions. You're also trying to do that with these interventional psychiatry treatments. So the idea is that the brain is an electrochemical organ. There's an electrical basis to how the brain works, and there's also a chemical basis to it. And you can bring about change through modulating, these different pathways. So you can modulate it with pharmacological treatments, the older generation, the newer generation. And with brain stimulation, you're looking at the electrical basis. And you can use electricity, ECT, deep brain stimulation, transcranial alternating current stimulation. You can use magnetism, which when it reaches the brain actually induces an electrical field, and then emerging modalities like light and sound. With light and sound as well, I'm not going to be presenting today, but you can bring about changes in synaptic plasticity, and the underlying basis is bringing about a change in the electrical organization. Then there's psychotherapy and also lifestyle-based interventions. A lot of our work is based on the understanding that these are mind-body illnesses, and chronic depression manifests itself through the inflammatory system, through the sympathetic parasympathetic nervous system, and it's well known with the overlap and comorbidity between systemic illnesses and brain-based illnesses. And we've been trying to see if we can actually use the periphery, if you can use the sympathetic nervous system, the parasympathetic nervous system, to actually modulate brain function. It's the reverse of, the brain and the mind chronic illnesses leading to systemic effects, but can we actually do the reverse? And I'll go through 2 or 3 research projects we're doing in that realm. So the next couple of slides, I'm going to focus on the brain stimulation, the clinical piece, and then ketamine. And then I'll move over after, over to the specific research paradigms. So I've mentioned how looking at disorders from a circuit basis is fundamental to interventional psychiatry. So this is the neural circuit pathway initially developed or defined by Helen Mayberg when she was in Toronto before, and then she left to Emory. She's now at Mount Sinai. But the idea is that, you can target very specific regions of the brain. So if you're doing deep brain stimulation, you put the lead in this deeper region. If you're doing TMS, the target is superficial. So you need to know the circuit, you need to know the target, and what you're doing with the target. Are you turning the knob up? Are you up-regulating the target, or are you down-regulating the target? So the based upon where you are within this circuit, you can get opposite effects. And there are so many details there with different frequencies in the same region. One can be stimulatory, one can be inhibitory. But this is the broad idea. Understand the circuit, find the target, modulate that target. So this is one slide which has most of the brain stimulation treatments out there. So you have deep brain stimulation, vagal nerve stimulation. On the x-axis, you have invasiveness, and on the y-axis, you have spatial resolution. So deep brain stimulation is very invasive, but it's very focal. Then you have ECT, and you have MST, magnetic seizure therapy. So the idea with magnetic seizure therapy as compared to transcranial magnetic stimulation is you still induce a seizure. TMS is non-invasive. With magnetic seizure therapy, you're trying to see if you can have reduced side effects with ECT because you have more control. You can steer the pathway of the electrical current with MST. And if you can avoid regions responsible for memory like the hippocampus, you have the potential for less cognitive side effects and the same kind of efficacy. And then you have a TMS with the figure of 8 coil, and then you have deep TMS. The difficulty with TMS is the trade-off between focality and depth. You can only go a few millimeters into the cortex. You cannot go deeper, it becomes diffuse. Then we have emerging modalities. I mentioned how you can use light, sound, in addition to electricity and magnetism to modulate brain function. So this is transcranial focused ultrasound. You can use what's called HIFU, high intensity focused ultrasound, which is like DBS. It causes cell death. Or you can do low intensity focused ultrasound, which is like TMS. It's non-invasive, but you can reach deeper regions of the brain theoretically. So this is 5 to 10 years of work before it's actually becomes available in the clinical paradigm. And then you have temporal interference, which is another non-invasive modality. And we are doing trials where we are trying to target the same region where we put electrodes in a non-invasive manner with temporal interference and with focused ultrasound. And then we have these other modalities, transcranial direct current stimulation. Some of these have very limited evidence because you cannot really understand the parameters in a controlled manner. So this is ECT on one side and TMS on the other side. With ECT, basically you have 2 electrodes and you're passing an electrical current, you're causing a seizure of the brain, and somehow it resets the brain, that in arrhythmia that I mentioned. With TMS, the idea is that magnetic fields can go right through the skull, and when they come in contact with a conducting tissue like the brain, it induces a small electrical field and an electrical current. It's non-invasive. You don't have the cognitive side effects of ECT. You don't induce a seizure. At the same time, you don't have the efficacy of ECT. With transcranial magnetic stimulation, we have a unique opportunity to change brain activity. I mentioned about the circuit, the node, and you upregulate it or downregulate it, but you can also simultaneously measure brain activity. And we can develop these closed loop systems where, it is personalized, the parameters are personalized to that individual. So it's been really interesting because you can understand the underlying basis and collect data in real time as you also stimulate the brain. This is a study which was done in Canada, Toronto, and Vancouver, which changed how TMS was delivered. So the previous paradigms, they were longer, so 26 minutes to 46 minutes. And this study showed that a 3-minute version, what was called theta burst stimulation, is non-inferior to this longer 40-minute treatment. So this was in 2018, published in The Lancet, and then this led to FDA approval, and overnight all the clinics moved to the 3-minute version. Why would you want to do 40 minutes if you can get the same benefit in 3 minutes? So that was the second generation, and this was 2018, 2019. And then people asked, well, if it's 3 minutes, why do people have to come every day for 4 to 6 weeks? Can we actually do multiple treatments and compress it over a few days? So this led to studies published last year, led by the Stanford group, where you do treatments by the hour. So you do 50 treatments, 10 treatments per day, completed over 3 to 5 days. So you take a brain scan at the baseline, you do an AI-based algorithm to find the specific region to target. It is personalized to that individual, and you target that region by the hour, and you give 50 treatments. So you've gone from 4 to 6 weeks of 20 to 30 treatments every day to 50 treatments over 3 to 5 days, which is personalized based upon that individual's brain scan. And this is shown to have rapid antidepressant effects, and almost all of our research now is focused on this, on understanding the parameters around accelerated treatments. If you look at the efficacy rates, regular TMS, is like your regular pharmacotherapy, psychotherapy treatment response rates, whereas with accelerated protocols, you can get response remission rates like for ECT. So you're looking at it needs to be validated and things like that, but you're looking at response rates, remission rates in the ECT range. Okay, I'll move over now to ketamine and S-ketamine. My slides got a bit disorganized, but I think it'll be a few here. So I'll go through ketamine, the various routes of administration, and the timeline for ketamine research in unipolar depression, and then some evidence in unipolar depression. So ketamine can be given through various routes. Think of the route it can be given. It's on the WHO essential medications list. It has been around since 1960. And the antidepressant effects have been more recent over the last 2 decades. And it's only at the sub-anesthetic dose, not at the anesthetic dose. It does not have an antidepressant effect at the anesthetic doses. When people are wide awake, less than 1 milligram per kilogram, that is when it actually has the antidepressant effects. And ketamine can be given through different routes, as I've said, and the intravenous route has the maximum bioavailability. Most of it reaches the brain, as compared to intranasal, where there's only 20 to 30% bioavailability. IV ketamine is a mix. It's R and S. It's 2 mirror molecules. It's like your left hand and your right hand. So what Janssen did was they isolated S-ketamine and then they patented the intranasal delivery device. And they did trials which led to FDA approval in 2018, 2019 for unipolar major depression. So this is the timeline, and ketamine has been a game changer in depression. For almost 5 decades, we were only targeting the monoaminergic system, which was minor modifications on the same drugs. How do you have the same efficacy but reduced side effects? And ketamine acts through the glutamatergic system. It's an entirely different mechanism of action, and it's opened a whole new paradigm for drug discovery in depression. And we have not had any rapid-acting antidepressants or rapid-acting anti-suicidal agents before. ECT is one. If you look at what's more rapid-acting, a traditional antidepressant takes a couple of weeks, whereas with ketamine, when people improve, it is, a couple of hours to a couple of days. So it is a rapid-acting agent, and it also has an anti-suicidal effect. So this is the quick summary of where we are with ketamine, with US FDA approval as an anesthetic agent, but really people starting to study its impact within treatment-resistant mental health conditions, particularly depression, in the 1990s, and then more studies being done. And as I mentioned before, J&J then doing a specific trial with the intranasal and getting approval. I've mentioned before that ketamine acts through the glutamatergic system. It brings about a prefrontal glutamatergic surge, which is thought to correlate with its antidepressant efficacy. There was also initial work suggesting that it's not only the glutamatergic system, but also other systems are necessary. So the glutamatergic system is necessary, but it's not sufficient, and the opioid system may also be involved. And this was an interesting study where they actually blocked the opioid system using naltrexone. This was from the Schatzberg group at Stanford, and they showed that the side effects with ketamine were not blocked. People still had, with the opioid blocker, the side effects of ketamine, but they didn't have the efficacy. So that raised the possibility that the antidepressant efficacy of ketamine probably requires not just the glutamatergic system, it also requires other systems like the opioid system. Ketamine is a drug of abuse. It's been abused for many decades. And this was an interesting study done by Carlos Zarate at the National Institute of Mental Health. If you're interested in knowing more about ketamine, one person to look up is Dr. Zarate. He's done a lot of these trials at the National Institutes of Mental Health. So this is an interesting study where they showed that in healthy subjects, actually ketamine induces, or it makes you worse. If you look at the MADRS, which is our clinical scales, among healthy subjects, it actually made some of the symptoms worse. Higher the MADRS, worse is your symptom severity. So as compared to depression, where the symptoms got worse. Again, the dissociative effects are not different, whereas the therapeutic effects are different. So the initial studies with ketamine were single dose studies, and as is the case, if you look at the psilocybin literature now, a lot of it is single interventions. Once you show efficacy with a single dose, then the question becomes multiple doses, and then the question becomes, how do you sustain that efficacy? I think with the ketamine, a lot of the research now is, yes, we know it has a rapid antidepressant effect, but how do we sustain this efficacy? It's not just enough to get people well quickly. You also need to sustain it. So ketamine has dose response parameters. There are particular doses where it is a lot more effective, 0.5 milligrams per kilogram, the standard given over 40 minutes. The typical curve is that it peaks within a day, and if you give a single dose when it's effective, the response rates are about 40 to 50%. If you look at real world samples, it goes away by the end of the week. So you need more than one dose. This is on average. For some people it lasts much longer, some people shorter. So you need multiple doses, and if you give multiple doses, you can increase the efficacy. You can take up the response rates, and it's actually double. So a standard course of IV ketamine now is about 6 treatments twice per week, and people have shown that twice per week is just as good as 3 times per week. So 3 times does not give you additional benefit. So that's why most clinics are doing 2 times per week. So then the question becomes maintaining response, and this is an ongoing area of research. And a lot of ketamine maintenance is done like ECT. It's more of an art than a science. So you try to take it down to the minimum frequency required for the person to be well. So as with ECT, you start off with 2 times or 3 times per week. You finish your acute course, and then you try to take it down once per week, once every 2 weeks, once every 3 weeks, once every month. You take it down to see what is the minimum frequency needed for people to be well. And that's an area of research. There isn't very definite evidence there on how exactly to do it. So intranasal S-ketamine, Spravato. So this was FDA approved, as I mentioned. And this is in Canada and in the US. It's quite expensive, and there are drug insurance plans which cover it, but you can see that the costs are pretty prohibitive. It has to be administered with an oral antidepressant. People come into the clinic, patients are not allowed to take home the treatments. They have to be in a monitored setting where the treatment is given, and then they go back home. It is like for clozapine, you have the REMS system. The idea is the same. So there's a REMS system for Spravato as well. And the reason is we want to know the long-term benefits and side effects with S-ketamine. There are a number of unanswered questions with S-ketamine. So this is how it looks in terms of it being administered in the clinics. I'll mention 2 pivotal studies which came out last year, and this will change the practice in terms of where ketamine stands within the paradigm of other treatments. So this is a trial comparing IV ketamine to ECT head-to-head. ECT as it is done now as compared to ketamine 2 times per week for 3 weeks. And this study showed that actually ketamine was non-inferior to ECT. This is a large study published in the New England Journal. 400 subjects, 200 got ECT, 200 got ketamine, and they showed that ketamine was non-inferior to ECT. So you don't have the cognitive side effects of ECT, but you're having the same response as you would see with ECT. So that raises the question, where should ketamine come in the treatment algorithm. So this is another trial where they looked at S-ketamine nasal spray as an adjuvant. So if you look at guidelines for treatment-resistant depression, when people fail first, second line antidepressants and they have some response, you add an adjuvant. You add aripiprazole, brexpiprazole, quetiapine. So they looked at what if you add S-ketamine versus quetiapine, and they showed that the response rates for S-ketamine was actually much higher than what you would see with quetiapine. Okay, so there are people looking at what you can do with ketamine to enhance neuroplasticity. Can we, combine it? Can we do multiple doses? Can we do psychotherapy at the same time, psychotherapy before, psychotherapy after? The combinatorial space is really large, and there are a lot of ongoing studies there. So I just want to summarize, for the people, clinicians in the crowd, as to what is the current state of evidence for ketamine in depression. Rapid onset of effects, acute efficacy. It's non-inferior to ECT, whereas the long-term efficacy, tolerability, safety, these are questions which need to be answered, and access is difficult. With S-ketamine, again, you have rapid onset of effects, not as rapid as IV ketamine, but relatively rapid. It's possible to do maintenance more easily with S-ketamine, but again, I showed you what the costs were with S-ketamine. With all the other routes, oral, sublingual, intramuscular, the evidence is really not as strong. Okay, so with that, I will move over to some emerging treatments in the next 15 or 20 minutes, and then I'll aim to wrap up, and then we can have time for questions. So I mentioned about how we're working with anesthesia and we are repurposing anesthetic agents. This is a study where we're actually blocking the sympathetic ganglion, the stellate ganglion in the neck. It is an outflow pathway along the sympathetic nervous system. So the brain interacts with the rest of the body through the sympathetic and the parasympathetic nervous system. The sympathetic is the drive, the parasympathetic is the brake in some sense. And in depression, we know that there's hyperactivity, overactivity in chronic depression of the sympathetic nervous system. So the question for us was, if we block the sympathetic nervous system, specific components of it, obviously the entire body is being autonomously run by the sympathetic nervous system, can we actually have, antidepressant efficacy? So this was a feasibility trial that's published. If you want to look into it, we showed that it was feasible, and we will be doing more definitive trials. Stellate ganglion blocks have been used for PTSD. We were the first to do it for treatment-resistant depression, with the same idea in PTSD as well. So this is another study which we have just completed. We are working to submit it for publication. So we compared nitrous oxide, laughing gas, to room air. And so almost all of our trials are placebo-controlled. And we were then funded through the American Foundation for Suicide Prevention to do a head-to-head trial of nitrous oxide versus IV ketamine. So we are randomizing people to get IV ketamine 2 times per week for 3 weeks, or they would get nitrous oxide. And this is to see whether, there is, what is the tolerability, what is the feasibility, what is the effect size of ketamine as compared to nitrous oxide. As I mentioned before, the response rates are about 50% or so. You still have another 50% who are not improving with IV ketamine, and there is a place for other treatments. We're also looking at new indications for ketamine and brain stimulation. I'm based at a general medical hospital. We have the largest MS program, multiple sclerosis program in the country. We have a very large concussion, traumatic brain injury program, and a stroke program. So we are trying to look at these modalities. I won't be going over that today, but just to give you a sense of looking at new indications. Just because it works in depression does not mean that it'll work when people have traumatic brain injury and depression, and it may have an impact on symptoms of concussion which are independent of its effects on depression. So that's what we're trying to explore and look at. So a couple of trials. I'm not going to go into the details of this. If people are interested, I can speak about this. You'll see that, all of our trials are, most of them are, placebo controlled. So this is comparing regular TMS to accelerated TMS. So we're doing the 3 to 5 days, the intense protocol versus the regular protocol. One of the challenges with intense protocols and also with ketamine is you can get rapid response, but how long is it sustained? You can also have rapid relapse. So trying to understand the dynamics of patient improvement with the regular as compared to the accelerated is actually important in terms of implementation within the clinic. So a few on the brain stimulation side, I mentioned about temporal interference. So this is a non-invasive way of targeting the brain. This is new. We are doing first in depression studies. This is work with MIT in Boston. So they did animal studies showing that you can target deeper regions of the brain non-invasively. So the idea is that the brain is a high-pass filter, and if you use high frequencies, the brain does not recognize it. But where these high frequencies actually interfere, so that's the idea of temporal interference, at the points of interference, the difference, so if you use 2000 hertz in 2001 or 2000 and 2010, the difference frequencies can drive neural change. So through modeling, based upon the brain imaging, you can come up with clever positioning of the electrodes so that the region you want to specifically target more deeply can be done. So this is modeling heavy, and theoretically it is possible to target deeper regions, and we are doing a first in depression study to show that you can actually bring about change in that region. I spoke about how we are looking at modulating the mind through the body. I've shown you one example with blocking the sympathetic outflow with the stellate ganglion block. This is another example where we're looking at whether we can bring about changes in brain, at least using the functional brain imaging modalities through facial stimulation. So there's a rich body of literature in stroke rehab. So when people have lost motor strength in their upper limb or lower limb, if you actually do pattern stimulation of the muscles, as you ask people to flex or extend their limb, it actually leads to neuroplasticity of the other regions of the brain. So we took the same idea around. We did single stimulation studies and then open label trials, and then we were actually funded to do more definitive trials. With both of these modalities I've shown, it is possible to make this a take-home treatment. And we want to keep people out of the hospital to the maximum extent possible. And we want, there's an emphasis on the prevention side, but also with TMS or ECT, people relapse. And we don't want people to keep coming to the hospital. We want people to be able to self-deliver treatments. So that's the emphasis here, and our line of research where, in 5 to 10 years, we do carefully controlled trials in the clinic with the idea that, people can then self-deliver once you know the right parameters. As with anything else in interventional psychiatry, we map out the circuit and we try to show where in the circuit that treatment is specifically targeting and how it is going to impact other regions within the circuit. So in this study, we are doing the pattern facial muscle stimulation in the scanner, and there is literature to show that it can have an impact on the amygdala. And we're showing whether in real time you can bring about changes in the amygdala functioning. So we have 3 ongoing trials. So patients essentially send us a picture of their face, and we use either 3D printing or fabric-based manufacturing to come up with a mask that is personalized to that individual. So it stimulates specific regions of the facial musculature in a patterned manner. So that's that. In the next few minutes, I'm going to speak a little bit about our third pillar of the program. So we have completed the pharmacology pillar, the brain stimulation pillar. The third pillar of our program is the digital interventions pillar. This is extensive work with computer science and the Faculty of Engineering. And we have a group around this. It started off as my hospital and the engineering faculty at my place, and now it has broadened out. So we do different modalities of data capture through virtual reality, through apps, and through wearables. And as people receive these other treatments, we capture this data in real time. We have the capacity to take any real life situation and render it in a virtual immersive setup. So people can actually go through these scenarios before they're exposed to it in real life. And the idea is to see how people react to stress and stressful situations in the virtual setup. And we've shown that that stress experience actually correlates well with people's experience in real life. And this is ongoing work with different bodies, and I'll briefly mention some of them. I'll give a concrete use of this. So we're working with the Canadian military, where PTSD is a big concern, and we are simulating deployment scenarios. So before military personnel are deployed, they can go through these scenarios and see what their stress response is like. So the idea is that, can you pull out a subset who are at high risk for developing PTSD? They're not deployed. They have psychotherapy and other modalities before they're deployed, because once people develop PTSD, it's a bit too late. And the same paradigm with the combination, we are actually using it in other contexts. So we have an emphasis on the 4P medicine approach: preventive, predictive, personalized, participatory. Almost all of our projects have people with lived experience actually advising us on the project development. And all the scenarios that I mentioned are actually built with input from people who have been through these circumstances. So that's some of our collaborating groups. I mentioned that it's a digital interventions and intelligence group, some of our funding bodies. So we have an emphasis within the clinic. As I mentioned before, it's a digital clinic. And then we also look at non-clinical populations with an idea towards prevention. I'll give you a snapshot of how we are doing digital interventions, digital therapeutics in the clinic, and then outside the clinic. So this is the third arm of the pillar. As I mentioned before, we have completed pillar 1, pillar 2. I've gone through the things, and now I'm only going to be speaking about the third pillar. So this is the flow which I've shown you before, and the third pillar is what you see here, the digital interventions, and it is embedded within the clinic where people are actually receiving the other treatments. So this is an example where we have integrated digital wearable-based data capture. So we are doing a trial with psilocybin and cognitive processing therapy for PTSD. So people receive a course of CPT, and in between they receive a single dose of 25 milligrams psilocybin. All of them have apps and wearables. So we're doing continuous, data capture. So it gives you very detailed sleep metrics, how long it takes the person to fall asleep. Is the person waking up right through the night, early morning awakening, REM versus non-REM, cycling through REM and non-REM. You get detailed information. Not as good as a polysomnogram, but you do get decent data. And then the activity levels, you get good data there. And then they're obviously doing ecological moment assessment, which means every day they're also doing scales on their phone. So it's a combination of objective and subjective data capture. So that's one. Another example, we're looking at lemborexant. The orexin system has been a new target for development of drugs for sleep disorders. So there are a number of them out there now, lemborexant, saltorexant. So many of them, just as the glutamatergic system was a new paradigm for drug discovery in depression, the orexin system has been a new paradigm for drug discovery in sleep disorders. So we have been looking at understanding changes in sleep with wearable-based data capture. So we have people receive placebo or lemborexant, and they'll be on the wearables where we're doing continuous data capture. So I mentioned about the work with the Canadian military where we are simulating scenarios, and we have people on the ground also with the wearables and the apps, and we've actually shown that the experience in the virtual setup actually correlates well with the experience in real life. This then led to other bodies. So we're doing work with Canada Post, which is our national carrier. It's a 5-year project where it's the same idea. We are developing. They have high rates of burnout, dropout, within the organization. So, we're doing prevention, trying to understand the most common causes for burnout and depression, and people basically not being able to function after exposure to specific stressful episodes, and are there ways to handle these things before people actually get into that situation. We're also doing extensive work within the digital space, trying to understand barriers and facilitators to adoption of measurement-based care and modalities for data capture. So we have a significant grant with Brazil where we're trying to understand. It's a study ongoing in Toronto where we're trying to see why clinicians don't want to do this, why patients don't want to do it, how can we get patients to do more of the scales? Is it based upon the kind of funding system? So is the challenge at the hospital level, at the university level, at the government level? What can be done? And a similar approach in Brazil as well, at the University of Sao Paulo, where they're trying to see what are the barriers and facilitators to uptake of digital interventions. So that's one example. I have 2 more slides and I'll stop. This is an example of where we have taken the same paradigm to the remote parts of Canada. So Canada's 10 provinces and 3 territories, and the territories they have large indigenous populations there, and they're really dispersed. So you see Labrador here, where there are a number of these communities along the eastern seaboard, along the Atlantic Ocean. There are 5 family physicians providing care for this whole territory. And these are thousands of miles apart, and the only way for the physician to reach is to fly to these small towns. And the physician is able to fly only once every 2 months or so, and all the care on the ground is provided by a nurse. They don't have physicians there. So what we have been doing is, can we have these people on wearables so that we can get continuous data capture? So the physician in Goose Bay here, which is thousands of kilometers away, has real-time access to the patient's symptoms, not just every 2 months when the physician goes there. And can we actually train people on the ground to better recognize the common symptoms of mental illness, including depression, substance use, death by suicide? These are common challenges there. So that's an example where we've extended this work to basically use digital interventions to enhance access to healthcare. The last slide I have here is about physical activity and how you can use digital data capture to enhance adherence. So we know that regular, vigorous aerobic physical activity, if you look at its evidence, is as good as pharmacotherapy and psychotherapy for mild symptoms of depression. However, the challenge is getting people to be physically active. So at the University of Toronto, we're working with the student mental health, where there is a physical activity program, but the uptake is low. And also I had discussions with the person running the physical activity program, where she said, I don't know at what time the students are actually doing the exercise. Are they doing the exercise? So I said, we have a solution for that. We could put people on the wearables and you'll exactly know at what time they're doing the exercise, what kind of exercise, aerobics, strength exercise. And the students also have access to their data in real time. They can see their improvement in sleep, activity, all of that as a function or as correlated with the daily amount of physical activity they're doing. So that doesn't mean we'll get everyone to be physically active, but if you go from 20% to 30% or 40% and you enhance adherence, that leads to significant benefit. So this is an ongoing trial where we have the current physical activity intervention program as usual compared to a wearable digital data collection based physical activity program. So with that, I'll stop. I've gone over the 3 pillars of the program. If people have specific questions on anything, I'm happy to answer them.
preguntas. O comentarios también.
I'll try my best to speak in English.
I'll just say, if people want to ask questions in Spanish, please feel free to do that. Reinhard will translate it to me in English.
Maybe it's a bit out of the scope of the presentation, but just I would like to get some insights on the threshold to define difficult to treat depression. Is it complicated to set it like in this setting in a general hospital? Who's evaluating those patients? Are they referring people with actual difficult to treat depression? And some insights on the selection criteria as well. Maybe it's a little bit outside of the scope of the technical aspects we already reviewed, but I'm sure someone else is going to ask about the technical thing. Can we get some insights on those?
Sure. No, I think it's a relevant question. And treatment-resistant depression, the older term, the current term, difficult to treat depression, it's not categorical. It's on a scale, and we have trials where we have people who are non-treatment resistant, or we may have people who are more treatment resistant. So the traditional definition, if you look at clinical trials, is 2 failed antidepressants with adequate dose and adequate duration. That's, if you're running clinical trials, that's what you would want to ensure before that's the inclusion criteria. For TMS, you go one step lower, so it's usually 1 failed antidepressant. So the amount of treatment resistance is a bit less as compared to with ketamine or with ECT. For as I mentioned at the outset, we sometimes get referrals from family physicians where they've not gone through these medications or psychotherapy, and we send them back, and then they go through, and if they've not improved, then they send to us. And based upon where they are, sometimes we get referrals where they say referral for IV ketamine, assess for IV ketamine, and then we say you have to go through TMS first. We don't offer IV ketamine unless you've had TMS before. The rationale for that is the scarcity of resources. It's possible for any physician to prescribe pharmacotherapy or get access to psychotherapy, but there's a limit to how many places are offering TMS, and it's only 1 or 2 sites which are doing IV ketamine. So we want to keep people who have failed everything else to come to IV ketamine. The same idea like ECT as well, like you would not offer ECT as a first option given how resource intensive it is. You would want to see that people have failed. We do have trials, we have some trials where we say people have to be treatment resistant, but that does not mean that they have to have severe symptoms. They could be mild, moderate, or severe. You can have persistent depressive disorder, persistent symptoms where you're treatment resistant, but you can be mild or you can be moderate. So we have studies like that where we're looking where, there are some studies where we have a hard cutoff that you're treatment resistance and you have severe symptoms. And then there are other studies where we have treatment resistant and you have mild symptoms, or we have kept it there. The challenges of heterogeneity, because we have to do these trials and we have to be able to replicate the results. And if you put everything together, then it becomes difficult. What may work for mild symptoms may not work for severe symptoms.
Thank you.
Thank you so much for your presentation. I think it opens up our perspective on these things, and it's something that we kind of haven't had the opportunity to work as intensively here in the Institute. I would ask, I'm studying child and adolescent psychiatry. I would want to say if there's any projects you're working with in this kind of population.
Yeah, so I'm an adult psychiatrist. I don't myself work with the child population, but we believe in an across the lifespan approach. So I work with people in the child department and people in the geriatric department, and our ketamine program has an age cutoff of 18 and above. So, and the reason for that is there are a number of unanswered questions with IV ketamine, and you would want to, understand this in the adult population well before you go into population where the brain is still developing. Specifically, if you look at the current evidence, earlier this year, the age limit for TMS, for depression, was taken down from 18 to 15. So now the age limit for TMS is actually 15. So that is one treatment, in the brain stimulation realm where the age limit has gone down. There are ongoing trials carefully controlled with IV ketamine, and there's preliminary evidence that you can have. So the studies are 13 to 18, not less than 13, but between 13 to 18, there are ongoing trials. You also have to keep in mind, so I have really focused in depression, but TMS, almost every disorder you see within the DSM is being actively studied with TMS, with brain stimulation. And the idea is the same. You try to find the circuit which is underlying that disorder, and you target it in a very precise manner. So, I won't repeat what I said with depression, but I'll give you 2 or 3 other examples where it is actually now approved. OCD, obsessive compulsive disorder, where you actually target the dorsomedial prefrontal cortex. With depression, you do the dorsolateral prefrontal cortex. With OCD, you do and that's FDA approved. You do get response rates similar to what you would see with medications. Another example is smoking cessation. You can actually get good response rates with specific targeted brain stimulation for smoking cessation. One difference is this idea of state dependence. So with smoking cessation, you ask people to think. So there is the salience, and they have to think. You have to induce craving when you stimulate the specific region of the brain. With OCD, they have to think of their compulsions as you're stimulating the dorsomedial prefrontal cortex. You don't do that with depression, but with OCD and with smoking cessation, you have to pair the two together to actually get the best benefit.
Thank you. Thank you.
There's an online question. We have an area specialized in perinatal psychiatry, and people there are asking if personality disorders are an exclusion for your protocol, like general protocol.
No. So I've gone through a number of things. So maybe I'll speak about the ones where there's clinical evidence. With IV ketamine, for example, the person needs to have depression. Along with that, they could have anything else. We don't exclude them. When I say anything else, if they have active substance use, we exclude them. They need to be in remission from substance use. But if they have PTSD, or if they have personality disorders or other things, as long as care is available around, that is fine. We actually let them in. And in fact, we just got my colleague in Toronto, they're doing a trial specifically looking at IV ketamine for borderline personality disorder. Given that depression and suicidality are two, critical components of borderline personality disorder. But within our clinic, we do give, and the response rates for depression is slightly lower as people have more and more comorbidities, but you still see improvement. With TMS, it's difficult to do some of these trials, but if you look at the evidence, the improvement rates are actually similar as you would see with, in the non-perinatal population. One thing which I did not cover in the perinatal field is, the rapid-acting depressants for perinatal depression. The pregnenolone, the whole brexanolone, which was a 60-hour infusion in the perinatal unit, which would lead to an rapid antidepressant effect. And then Sage, they went with the oral analog of these medications, and you're actually targeting the GABAergic system with these medications. So there's a whole exciting development for perinatal depression around relatively rapid acting treatments, going through an entirely different mechanism as compared to what we would use otherwise. There are also people doing these non-invasive trials like TDCS, TACS, where the side effects could be relatively lower, but again, the efficacy would not be at the level of TMS. With ketamine, we don't do for perinatal depression for all the different reasons and the unknowns. And I'm aware of some case reports, but there are no well-done controlled trials, and we don't offer IV ketamine. And why would you want to offer IV ketamine when you have something like brexanolone, allopreg, these other medications which are relatively safer?
Me gustaría ocupar el traductor virtual. Gracias. Mi nombre es Yehu Garfias, trabajo en el servicio de urgencias. Y mi pregunta es si hay un manejo paralelo a toda esta tecnología y todo este avance tecnológico para el manejo del tratamiento, del acercamiento con la familia, con el ambiente, con los estresores sociales, ambientales que pueden presentar los pacientes también que llegan con ustedes.
The question is if there is any parallel management related to the patient's family, the patient's environment, or any related to this interventional treatments.
Yeah. So with ketamine, it is delivered by anesthesia, and just like any other procedural treatment, you need someone to accompany them back from the hospital. So that's a requirement. If it's like you're doing endoscopy or these other procedures where if you have received an intervention, you don't want them to drive back home being sedated. So we have a requirement that someone has to accompany them back home. It doesn't have to be a family member, but it has to be someone who would accompany them back. For TMS, we don't have that requirement. It could be, people can come in. We have people who are working who block, 15 minutes or 20 minutes a day. They come to the clinic, they receive the treatment, then they go back to work. They don't need to be accompanied. When you speak about the rapid acting protocols where by the hour you do 10 treatments, a lot of these people are often sick, and then we have to involve someone to be present with the person right through the treatment period. We try to have as much of the family involved to the extent possible. On our digital pillar, for example, with the app where the scales are sent, you can have the family members actually do the scales. So we have the patient versions, PHQ-9, these scales. So our goal as we work with the geriatric program is to have the family members to do the scales as compared to the patients themselves. So the more involvement there is with other members of the family, we know that the response rates are often better.
Una última pregunta. ¿Los recursos financieros para el apoyo de estos tratamientos hacia el paciente son por parte de ustedes o de alguien más, de alguna industria?
The question is, how do the patients are supported economically to receive the treatment?
So that's a critical question. As I mentioned before, the cost of these treatments are, particularly the new and emerging ones, are pretty high. And TMS, I'll keep it specific to TMS and to ketamine, because everything else I've shown is all experimental. It's all within the REB protocol, and you receive it as part of a clinical trial if you're eligible. the clinical ones, there are TMS and IV ketamine or intranasal S-ketamine. With TMS, we have provinces which actually cover TMS and we have provinces which don't. So TMS, people have access to it. With ketamine, you have the intranasal version, which is quite expensive. And we have a single payer health system in Canada as compared to the US. We have less private system. So people are able to access it on the private side, whereas within the government side, I think it'll take a few more years for it to be more widely available. With IV ketamine, there are 2 provinces who have started to cover IV ketamine over the last 2 or 3 years, and then other provinces are working on it. The challenge with IV ketamine is it is off patent. It has been around since 1960s. No one is going to do these large trials when there's no patentable way of doing it, where we know that there is the evidence, but to get an indication, to get FDA or Health Canada to approve, you need to do those large trials. And what Janssen J&J did was they patented the delivery device, and they went for the intranasal, but IV ketamine is off patent. So I don't foresee us having the same level of FDA Health Canada approval with IV ketamine for that particular reason. It's not, no pharmaceutical company will take something which does not have a patent and deliver a treatment indication for it.
I have a question for the VR technology. You told us that you're using it for like prevention for PTSD, like for the soldiers before the deployment. But are there any protocols for when they have the PTSD or for some other entities like phobias or OCD?
Yeah. So the first studies with virtual reality was, as you said, for anxiety disorders and then obsessive compulsive disorders, the idea of exposure and response prevention. So, if you have a phobia for spiders, expose them to the spiders in the virtual setup. If you have a fear of climbing stairs or of heights, expose them to that within the virtual reality setup. That's how the initial studies were developed. Our interest has been to actually collect different modalities of data. So as people are doing virtual reality, we have them hooked to a machine which actually covers, which actually collects different modalities of objective data. So skin conductance, heart rate variability, oxygen saturation, EEG. So a number of these parameters are collected in real time, not just the subjective experience. We are obviously doing scales and collecting their subjective experience, the subjective units of distress, but we're also collecting the objective data, and we're trying to put them together to come up with individual signatures of stress response. So if you have high stress, your objective and subjective parameters look in a certain manner. So we're using data-driven AI-based algorithms to come up with that signature of putting together these different modalities. Specifically, we are interested in prevention. So it gives insights to people as to how they're handling these situations. To make it a bit more concrete, often, you've not seen the spider, which gets you into that kind of a setup. And a lot of depression, PTSD, these are in circumstances where people are often there for the first time, or they're in the same situations which they've not been before, and they're not able to handle it. So are there ways where you can see what are the situations where people may not be able to handle them? Can you give them tools so that they could, from a CBT perspective, they could think, feel, behave in a different way before they actually get into that? A lot of additional work needs to be done to make this really usable, and our goal is in the next 5-6 years to have a product which the military personnel can use within the service. We have shown proof of concept we did a feasibility trial, we'll now be doing an efficacy trial. And a lot of what I've shown takes 5 to 10 years. You first show that it is feasible, that's a 3-year trial. Then you do another 3 to 4 years, a second trial to show, what's the dose, what's the duration. Once you show efficacy, then you have to do a large multi-center trial, to you would have 300, 400 subjects and show that it is actually efficacious. So this takes 3 years, another 5 years. So he's speaking about 10 years.
¿Alguna otra pregunta, comentario final? Bueno, pues agradecerles al doctor Reinhardt, al doctor Venkat. Thank you very much for coming. You will be always welcome when you would like to share presentially or online.
Yeah.
Thank you very much.
Thank you for the invitation. And if people have questions, feel free to reach out to me. And everything which I've shown today, if people are interested, whether it is the way we've developed the program, our protocols, our consent forms, we're happy to share any of them.